That's rolling. I'm going to close the door and I'll let you in.
Okay. Oh, I think he needs to reset the. Okay, I got that. Okay. Yes, I can. I am ready. Okay. Hello and welcome to Your Family's Health. My name is Dr. Janine Cookerard from the nursing department here at Nassau Community College, and today we're turning the heat up. And for some women, you'll see that we are doing quite well with this, literally. We're talking about menopause. So, it's a natural stage of life that brings hot flashes, brings mood swings, an occasional urge to turn up your freezer. But we will see here. Don't sweat it. We've got an expert device. And this is my guest today, who I'm honored to have back with us, Dr. Peggy Margetson. Did I say that right?
You did.
A pioneer leader in women's health who is board certified women's health nurse practitioner with over a decade of experience. Dr. Peggy is the founder and CEO of Trust Women's Healthcare, with locations in both Brooklyn and Deer Park. Her work has been featured in ABC's Here and Now, Forbes Health, Essence, the Baltimore Times, Rolling Out magazines, and much more. Dr. Peggy, welcome back to Your Family's Health, the voice of Nassau Community College 90.3 WHPC. Welcome to you.
Thank you so much for having me back.
It's so good to have you back. And as a graduate of NCC, it's a nursing program, it is awesome that you're able to come back and to honor us with your presence, talking about a very important topic. So how do you define menopause?
So that's a good question. With menopause, the term itself is when a woman has not had a period for one full year. However, for many women out there, you can be in perimenopause, which is the transition before you get to that for at least 7 to 10 years. And in Black women, it can be 10 years or more.
So when you're in perimenopause, tell me the difference in what you are feeling or what your body is doing. Can you define perimenopause versus menopause for us?
Sure. So perimenopause is that transition where that's where all the symptoms start to hit you. And it varies woman to woman, person to person. So, some may experience irregular periods where they're not getting their periods often, or they feel like it's coming like the floodgates. That's where hot flashes, where you might not get the sweating, but you might get a heat where you just feel hot all of a sudden, or you might get mood swings. All of a sudden, you're irritable, and things that used to be cute that your partner would do, you find it's a little bit annoying. You start to have a reduced libido where you're not interested, and your partner starts to question if the fizzle in the relationship has faded out. Also, you start to not sleep. You get insomnia where you're up between 2 and 4 in the morning and you're twisting and turning and you're not getting. You might get palpitations. You might get frozen shoulder where your joints hurt. You might feel fatigued. So there's a combination of symptoms. But again, because these symptoms overlap with so many conditions, menopause is always thought of last.
Yeah.
And so with menopause, that's when the final sensation, like 1 full year of not getting a period. So women, if you get your period, 11 months ago and now it hits, that year starts all over again.
So is it a dangerous period in there when you're talking about your perimenopausal and your period stops maybe 10 months and you're still having intercourse with your partner? Possibility of pregnancy. Is that possible?
Absolutely. Because you're still ovulating. So your ovaries are still trying to work. So I tell women around this time that, yes, you still can get pregnant. So, contraception is definitely indicated because especially if you have irregular periods, you don't know when you're ovulating. So it might be that the timing might be right and you might be coming in and having other symptoms.
And having a congratulations.
Exactly, correct.
So what age are we talking about with menopause? Is it vary? Is it familial? What age are we thinking?
So by studies, average age is 51. However, going back to what I said earlier in terms of perimenopause can be 7 to 10 years. I'm finding women are experiencing menopause as early in their 30s.
Wow. So why is that?
So there is a thought that there's about 1 to 2% of women that experience premature menopause, and where their ovaries just literally stop working, and they have all of these symptoms. So that's one facet of it. Perimenopause can start in your late 30s, and you can go through full menopause in your 40s. So it varies from person to person, woman to woman. And so the big thing is that if you are having symptoms that you feel are not the norm for you,
Yeah.
you have to get it evaluated.
Okay.
Because there's no rhyme or reason why one person may have menopause earlier than the other. I also tell women to talk to your mothers and grandmothers and aunties, because you'd be surprised. Genetics plays a big role, early or late, because there are women that are can go through menopause late in life as well. Talk about late 50s.
Yeah. Yeah. So if you have, say, for example, a baby late in life, can that put your menopause and push it back at all?
Not necessarily, because now we're finding postpartum perimenopause is a thing where because women are delaying childbearing. So now women are getting pregnant in their mid 40s. So right after that surge of estrogen that you get during pregnancy, then now you're in the postpartum period, and now you're starting to have all of these symptoms. Because remember, estrogen makes you feel good, you feel great, you have lots of it during pregnancy. So now after postpartum, now you're starting to get all the symptoms. So you're going right from postpartum, which can be debilitating in itself with having a brand new baby, and now you're going into perimenopause. So that's a new thing.
So tell me about, how do you know when a woman comes into your office and she's trying to confirm actually whether she's in menopause or not? Are there any blood tests that you take? What is the role of estrogen and progesterone?
So that is a great question. So at my practice, we have a mission that every woman is heard. So it's important to really listen to the patient and listen to what they're experiencing, because everyone's experiences are different. And like I said before, although you may be in the age of perimenopause, we have to rule other things out. So menopause, perimenopause is a clinical symptom-based diagnosis. Lab results do not confirm or corroborate the condition. Because with our hormones, specifically estrogen and progesterone, they fluctuate from day to day, week to week. So again, am I drawing your blood at a time where your estrogen is at a peak level? So then at that time, it's going to dismiss the symptoms that you're still having. And that's the thing with perimenopause is the fluctuation of hormones. And that's why the symptoms are not coming daily. It may be sporadic or intermittent because of the webs and flows of your hormones. So it's really listening to the patient. And that's what I love about menopause. And it's really listening and individualized care. And you have to take the time to do so. And be able to do the workup. So I love running labs just because I like to have a baseline, make sure everything else is going well as just looking at your hormones, specifically estrogen, progesterone, and testosterone. But once we've ruled everything out, then we can deduce from the process of elimination that is probably perimenopause. And I'll also say that most women, when they start to experience these symptoms, they're going to their internist, their cardiologist, they're going to their GI, they're going to everyone else, because again, menopause is not thought of as in a hierarchy as a symptom or a condition that needs to be evaluated first. We start to rule out everything else and kind of leave menopause at the wayside.
So why do we do that? Is it because it's deemed as a natural process of life? Or it's not really a disease per se, or issue or illness? So is that why it's usually left as maybe treated last or dealt with last? Or maybe it's a social thing where women don't take it serious? Why do you think it's put to the back burner?
It's multifactorial.
Okay.
Menopause is still a taboo. It's still misunderstood. The thing with menopause is, I remember in my training, I didn't get that much menopause, and you can probably attest to that as well. So there is a lack of education within providers. There's a lack of education within the public. So menopause is thought, because it's a natural transition, and any woman who is born with an ovary will go through menopause. That is unequivocally correct. So because there's a lack of knowledge with midlife health, providers start to think of other conditions and rule those out first before menopause.
Okay.
Because again, with menopause, what is the treatment, right? There are so many different treatments. And again, providers are not listening to women, and they try to put it in a box of something else. And don't get me wrong, it could be. It could be other conditions. I don't want listeners to feel that everything goes down to menopause. But if for providers out there, if you have a woman who's coming into you with certain symptoms, menopause has to be in that differential diagnosis along with all the others.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Janine Cookerard, and today we're talking about menopause. My guest today is Dr. Peggy, a pioneering leader in women's health, who is a board-certified women's health nurse practitioner with over a decade of experience. Dr. Peggy is a founder and CEO of Trust Women's Healthcare in 2 locations, both Brooklyn and Deer Park. So what is the treatment for menopause? Is there any hormonal therapy that we give patients?
So menopause treatment is based on the individual and based on women. So when a woman comes into me and we are discussing menopause and the symptoms, and once we've ruled everything out and we know it's unequivocally menopause, we talk about the most effective, which is hormone therapy. And that's where also the taboo comes in. Hormone therapy, for those who don't know, is that estrogen, progesterone, and also testosterone, because testosterone is a hormone that women do produce. But there was a women's health initiative that came out in 2002 that debunked hormone therapy, where the study came out and there was a huge press conference that says estrogen is bad and it causes breast cancer, stroke, heart disease. And I know you remember that study. Yes.
I do.
So that really was just devastating for women in general. And over the decades, you know, the providers have really looked at that study and said, wait a minute, how is it that it can cause these things when we're replacing what women have lost? And in demystifying this study and really kind of dissecting it, there was one type of estrogen that was used in this study. And again, they saw a lot of the flaws with the synthetic estrogen with the women who have uterus. And then also there were a lot of women who already had certain conditions that where estrogen does not increase cardiovascular disease, it doesn't increase your likelihood of stroke.
Okay.
And now what we're using is natural bioidentical hormones, estradiol. And estradiol, there is no link to initiating breast cancer, heart disease, or stroke. So it was such an injustice that happened with this study. And there was a huge press conference. So there was a whole generation that did not get any hormone therapy. So when I speak to women, I tell them about this study because there's still the black box warning. There's still providers that are practicing with this old thought that hormones cause all of these issues. And women, we need to know that our estrogen, progesterone, specifically estrogen, is all over our bodies. We have estrogen receptors all over, and that is what's protecting our heart. That's what's protecting our bones. Once we lose it, we don't get it back. So replacing it is really important, not only for symptom base, but it's important for prevention. So we discuss, we discuss estradiol therapy in forms. There's different forms that it comes in. There's a transdermal, there's an oral, there's also like a gel and like an aerosol mist. And that
I didn't hear about the aerosol.
Yeah, there's an aerosol mist that you just spray. Yes, I think
and
it's
where do you
amazing.
spray it? It's on
your forearm.
Really?
And you rub it daily, and it's actually quite nice. And however, you know, it goes with the prescription and the coverage. So that's an option that is available. And though estrogen, what it'll do is it will help you with the symptoms of hot flashes, brain fog, joint pain, fatigue. So a lot of the systemic symptoms that women experience during menopause. Simultaneously, we do, if a woman still has her uterus, we introduce progesterone. But I love progesterone even if a woman does not have her uterus, because progesterone is your sedative hormone. So it helps with sleep. It helps with anti-anxiety properties. So for my patients that I put them on progesterone, they come in and they're like, I was able to get a full night's rest. They are so happy, and they're having their quality of life back.
Yeah.
And last, I always introduce vaginal estrogen as well, because we don't talk about the vagina and the vaginal health that happens during menopause.
Right.
And it's the genitourinary symptoms of menopause, where you experience vaginal dryness, painful intercourse, and increased risk of urinary tract infections that, if left untreated, you can become septic, and ultimately you can die.
So this estradiol that you're talking about, there are no side effects, or if there are side effects, what are the side effects?
Yes, everything has side effects. Yes. And side effects for specifically with estradiol is breast tenderness, because you're introducing estrogen. You have some bloating, you may have some headaches, nausea, but again, especially with the transdermal, it does not increase your risk for blood clot, stroke, heart disease, breast cancer. Yeah. So I think that's the important fact for listeners to know, that those are the main things that this study came out and said, and we were able to really demystify and to have subsequent data that shows that this does not cause those things.
So you talked about the estradiol in terms of bone health. With women. So I know you see women that are menopausal, obviously, and you put them on the estradiol. Do they still need to continue with their vitamin D, calcium supplements after they are on the estradiol? Or do you see that, is there any significance in maintaining the bone without the supplement, calcium or vitamin D supplements?
So supplements are still important. Your antioxidants are very, very important, because again, this is menopause, midlife health. It is multifaceted. So it's not just the hormone therapy, it's still the vitamins, the antioxidant, vitamin D for bone health, getting your preventative screening, getting, omega fish oil for heart health. So I want women to understand that it's not just, I'm on a hormone replacement therapy and that's it, I don't have to do anything else. You still have to continue with all the supplements that helps for overall health and wellness, in addition to management of menopause.
So when a woman experiences menopause, take me back to some of the symptoms that they experience. Weight gain, one of the things that they experience. How significant is this? Has the studies elucidated any amount of any number? You gain 10 pounds, 20 pounds. Is it a morbid obesity? Because some women will say, well, I've never been this big before. But is this lending to a morbid obesity, or just a couple of pounds that we're talking about? What is it? Water weight gain, or what is it?
It all depends on what your baseline is. So women will gain weight during this period because of the redistribution of fat that happens from the lack of hormones. Women will gain weight specifically around the mid area. That's where women will start to notice that around the abdominals area, that they're feeling more bloated, they're gaining more weight. So what happens as you start gaining more weight, you become into this category of maybe obesity or morbid obesity. And that's where other conditions start to set in, such as hypertension, high cholesterol, diabetes. So it doesn't matter. Women will come in and say, I haven't changed anything. If anything, I'm exercising more, I'm eating better, and I'm still gaining this weight. And it's because of the redistribution of fat that occurs, because the narrowing of the vessels that happens. So there are other treatment options. I talk to women about a whole facet, from the GLP-1s to really working with nutrition, to really find the foods that will help during this midlife time. There is also different supplements that also do help. And I also, with hormone therapy, that there are some weight loss properties that do actually help with that, because we are reintroducing estrogen that you've lost.
So you talked about, and I know that there are significant mood changes as it relates to menopause. How can, when we talk about this, I'm sure the partners understand that, my wife or my girlfriend is going through menopause. How can they offer some support? I mean, if at all.
It's so interesting you asked that question because, my husband and I were having the conversation and he's heard me talk about this all the time. And I think that, it's misunderstood what is going on. Everyone talks about the change, and it's important for support persons, people in the lives of women that are going through this, understand that it is not their fault. It is the body that is literally changing. She still finds you attractive. She still loves you. She may not like you at this point at all, but that can pass. But it's important to understand. I have partners also come in during appointments that I have with patients so that they can hear and understand what they're actually going through. Not that they don't believe their partners, but with the fluctuation of hormones, that is what is leading to the erratic and the mood instability within women. And also the fatigue. If you think about it, if you're not getting any sleep, no one's going to be happy. Yeah. Everyone is going to have some type of irritability. So I think it's important to know that, and to know that there are, like I said, options. And hormone therapy is just one option, right? Because there are women that are unable to take hormones. There is also other medications that can also help. There are supplements that can also help as well. So I think it's important to understand what women are going through during this time, and the symptoms may hit some more than others. But no one is alike. Just because you only have one or two of the symptoms doesn't mean that you're not going through this change.
You're listening to Your Family's Health with the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Janine Cook-Garrard, and today we're talking about menopause. My guest today is Dr. Peggy, a pioneer leader in women's health who is board-certified women's health nurse practitioner with over a decade of experience. Dr. Peggy is the founder and CEO of Trust Women's Health Care, 2 locations in Brooklyn and in Deer Park. So let's talk about these hot flashes. Because I'm experiencing some of that right now. But in all seriousness, the hot flashes, I know that our partners, we sleep with them, we turn the fan off, we turn the fan on. What is the best, I would say, treatment for hot flashes? You talk about estradiol. I know the medication. But is there anything outside of that will decrease your tendency? Is stress bring on the hot flashes? What brings them on exactly?
So hot flashes which are vasomotor symptoms, are caused by the thermoregulation in the brain. So that becomes narrow, and that's when women start to experience the increase of heat. And let me say, hot flashes can come in a form of just all of a sudden having like a heat that comes within you, and you don't know where, and you're looking around and everyone else seems to be cold. But you're like, where's this heat coming from? It can accompany with sweating. It doesn't necessarily have to. It can also happen at night, where you wake up and you're feeling drenched, and that also wakes you up, and where you're feeling the lack of sleep. So that's where it comes. It comes from the thermoregulation in the brain. So there are a lot of other symptoms. There are some medications such as Veoza that has come out that helps with the vasomotor symptoms. There is SSRIs with their antidepressants like paroxetine that also help. Gabapentin, which is known for like nerve pain, taken at bedtime, can help with the night sweats. There are also supplements out there that also help, such as black cohosh, ashwagandha. There is estrogen supplements that also help. I know Black Girl Vitamins, they do a great supplement called Menochill that has the black cohosh, ashwagandha, and red clover all put together that helps with it.
And where do you get that from?
Online. It's Black Girl Vitamins. So there are supplements that do help. But again, these supplements and medications help with the symptoms of the vasomotor symptoms that you're experiencing, the hot flash. It is not preventative.
Okay.
When we discuss hormone therapy, it not only helps with the symptoms, it also helps with prevention. So which is very important.
So tell me, when a woman gets surgery, and say, for example, they get their uterus and their ovaries taken out, is that an automatic menopause because of the surgery? And what are we doing for that? What do we try to do?
Absolutely. That actually, removal of both the uterus and the ovaries, when a woman comes out of surgery, it's almost like the menopause hits them even worse than someone who goes through natural menopause. Because in natural menopause, your ovaries are really still trying to work. They're trying to produce your hormones.
Right.
So that's why you may have some good days and some bad days. But when it's removed, you have nothing there. So depending upon the reason for the hysterectomy, it is definitely indicated to have some treatment almost immediately, especially in women who are younger than 40. It is important to initiate hormone therapy if that is indicated, if there's no contraindications, because if you're in your 30s and you're losing your hormones, your protection from heart disease, bone disease, and even your brain, when you get to your 50s, that's when you start to really see the effects of the lack of hormones. And really, it's really putting them at risk for some serious medical conditions.
So the lack of estrogen, can it lead to things, you mentioned brain fog, but can it lead to dementia? Can it lead to really declines in your thought process, in your cognitive functioning?
Absolutely. So there is ongoing studies right now that show that there are estrogen receptors in the brain. And when you lose those receptors, that's where the brain fog comes in. And there is a link to the lack of estrogen and dementia and Alzheimer's that plays a part. And then also things that used to come naturally easy to women start to become difficult. And that is because of the lack of estrogen. And that's why this is so fascinating. And I feel that it is not spoken enough because of the transition during this time and the effects on all of the body. It's a whole body experience. It's not just one thing. So it can lead to severe cognitive decline.
So how late is it? I mean, I know that you have some women who have experienced menopause years ago. Maybe they're in their 8th decade of life or 9th decade of life. Can you start this estradiol at that time, even though they have been through menopause for years, and estradiol is now then effective?
So it goes back to listening to the patient, listening to what the symptoms are. There was this timing hypothesis that said, if you start hormone therapy within 10 years, less than 60, there are benefits, but over 60 you can't. But we know that timing hypothesis is definitely flawed because women will still benefit even in their 80s with estradiol. I think women, grandma that is 90 years old can still benefit from vaginal estrogen. Can absolutely benefit from that. So I think it's definitely speaking with the patient, having the conversation, seeing what their symptoms are, and being able to offer them for their quality of life. And again, I can't stress shared decision making enough.
So talk to me about your practice. And I'm so excited about your 2 locations, one being in Brooklyn, gorgeous office.
Thank you.
And now you're in Deer Park, I'm understanding.
Yes.
Tell me about very briefly, because we're about to.
Sure. So Trust Women's Healthcare is mission is 2 locations, 1 mission, and we are really want women to be heard, have an experience, really get the care that they need, and we also provide a platform and access to women regardless of socioeconomic conditions, culture, race, and insurance. We believe that all women deserve to have great health care. And me and my other providers are doing just that.
Give me your website.
www.trustwomenshealthcare.com, and we're also on all social media platforms.
And I could just log into that email and get all the information, book my appointment, and come in to see and get my estradiol.
Correct.
For my menopause.
Absolutely. Yes, we have same-day appointments. We have our staff that's there to help you schedule your appointments. We are here to listen to you. And it may not be accomplished with one appointment, but know that we are dedicated and committed to making sure that you receive the best health care possible and to be empowered to make your decisions regarding your health.
I'm excited. So I want to say thank you for being here once again, Dr. Peggy, the founder and CEO of Trust Women's Healthcare in 2 locations, both Brooklyn and Deer Park. Thank you for taking the time to come down and to see me for the 2nd time, possibly 3rd.
Absolutely. Thank you so much. I am so passionate about women's health. I could talk about this all day. And I thank you so much for having me and allowing me to discuss this important topic.
You're very welcome. This is Dr. Janine Cookerard from the Nursing Department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
Oh, thank you.
I don't know. I don't know